I guess everybody's beginning to get spring fever along about this time of the year. I hardly blame people. The sunrise was beautiful this morning. Today we hope to cover at least some aspects of one of the more common forms of congenital heart disease and discuss some of the pertinent concerns of those of us who deal with this common condition. And I think from looking at the program, it's evident the different aspects that we consider to be important at the present time. First, I'd like to make some general comments regarding congenital heart disease. And if I could have the first slide. There are very few studies, forward studies, that give us any information about the frequency of congenital heart disease. Most studies are retrospective studies that appear in the literature. But one such study coming from Columbia in New York, where 6,000 some newborns were examined right at birth. In fact, the mothers were followed all throughout pregnancy. These babies were examined immediately at birth and then given very careful histories and physicals every month during the first year of life. And from these 6,000, there were 50 cases that were diagnosed as having congenital heart disease sometime during the first year of life. This amounts to approximately 0.8% incidence. Now, the authors recognize that some cases of congenital heart disease were missed because the small atrial defects would not show up during the first year of life, and other anomalies would also be missed. And so generally I like to cite the figure 1% of all live births. In this series, it's interesting to point out that a number of them did not survive beyond the first month of age, even in this series at Columbia, which was just a few years ago. The next slide, please. Now I want to just show this to point out the relative frequency of the different common congenital heart lesions. And this column represents the data from Boston Children's Hospital reported by Dr. Natus, and the right column the data reported by Dr. John Keith from Toronto Children's Hospital. And these numbers are the percentage frequency of congenital heart lesions. And you can see in both series ventricular septal defect was the most common lesion, followed by tetralogy of flow and patent ductus arteriosus, and then tailing off down here are pulmonic stenosis, atrial defect, aortic stenosis, and transposition of great vessels. So ventricular septal defect, the subject of this morning's presentation, is the most common form of congenital heart disease. The next slide, please. Finally, I just want to go back to Maud Abbott's old data presented quite a few years ago. Some of you will recall that she was the first in the United States, really, to begin collecting information on patients with congenital heart disease. And she reported the detailed pathological findings in over 1,000 congenital hearts that were supplied to her at that time. And if we look down here at patent ductus arteriosus, she had, at ventricular septal defect, she had 50 ventricular septal defects in her series. And over here we have the age at the time of death. And this, of course, was before the era of antibiotics and before definitive or palliative surgery. The maximum age at death in her series was 49. She had one fetus, and the average age at death was 14 years. These would be untreated patients with ventricular septal defect. Lights, please. Well, I think this will suffice by way of introductory remarks. And now we would like to present a patient for you, and Dr. Stanley Higashino, one of our cardiac trainees, will give the case presentation.
The case to be presented today is a 4-year and 8-month-old Caucasian female who was completely asymptomatic during her entire neonatal period, although a heart murmur was first heard during a routine examination at 4 weeks of age. However, beginning about the 3rd to 4th month of life, the child became a feeding problem, developed frequent respiratory infections, and also developed a persistent cough and progressive dyspnea, tachypnea, nocturnal sweating, and generally not doing very well as far as gain weight was concerned. However, there was no history of cyanosis. Shortly thereafter, at the age of 5 months, she was admitted to this hospital for the first time in frank congestive heart failure and was digitalized at that time with a fairly good response. Cardiac catheterization studies were done at this time, which revealed a large ventricular septal defect and a pulmonic to systemic flow ratio of 2.5 to 1 at rest. The mean pulmonary artery pressure at this time was 50 millimeters of mercury. However, because of the small size of the infant and because of the favorable response to digitalis, it was decided to delay definitive surgery until a more optimal time when the child was older. The child was then readmitted to this hospital at the age of 3 years and 8 months for a repeat catheterization. Physical examination at that time demonstrated a small acyanotic child with a marked precordial bulge, a thrill, and a grade 3 out of 6 harsh holosystolic murmur along the low left sternal border, and a single but markedly accentuated second heart sound. Electrocardiogram demonstrated combined ventricular hypertrophy. Catheterization studies done at this time showed that the mean pulmonary pressure had increased from the previous 50. It was now up to 80 millimeters of mercury. Again, at this time, contrary to the previous catheterization, there was no demonstrable shunt by oxygen saturation at rest, but a significant left to right shunt was produced after the administration of 100% oxygen. Also, after the administration of oxygen, the mean pulmonary pressure dropped from 80 down to 70 millimeters of mercury. At this time, the patient was believed to be operable because, number one, the presence of a thrill and a loud systolic murmur in the absence of cyanosis or polycythemia indicated that she had primarily a left to right shunt. The catheterization findings indicated that the pulmonary hypertension was at least partly hyperkinetic in origin, and because of the electrocardiographic evidence of combined ventricular hypertrophy rather than right ventricular hypertrophy. However, because of the increase in pulmonary pressure, it was deemed advisable not to delay the surgical procedure any longer than necessary. And so shortly thereafter, the ventricular septal defect was surgically closed, utilizing extracorporeal circulation. The patient had an uneventful postoperative course and has subsequently done extremely well. At the age of 4 years and 8 months, this is now 1 year postoperatively, a repeat catheterization was again performed. Although the child still has significant pulmonary hypertension, there were some encouraging results that we obtained, as the mean pulmonary pressure had dropped from the preoperative level of 80 millimeters of mercury to a level of 60 millimeters of mercury postoperatively. Also, the surgeons would be happy to know that there was no intracardiac shunt demonstrable at this time, indicating that the surgical procedure was a complete success. And thirdly, the pulmonary resistance, which was 80% of the systemic resistance preoperatively, had now decreased to only, well, not only, but decreased now to 65% of the systemic resistance. Dr. Donald Deseles will now present the radiographic findings.
Steve, could we have the first slide, please? This is a PA and lateral film of the chest, which was made when the child was 5 months of age. And these films show the characteristic findings of a ventricular septal defect. The heart's enlarged, the pulmonary vascular markings are increased, and on the lateral film there's posterior deflection of the barium-filled esophagus due to an enlarged left atrium. The atrium is enlarged with a ventricular septal defect because of the increased blood flow through the lungs coming back to the left atrium. Left atrium then has to handle a lot more blood than normally, and it therefore distends. In contrast, an atrial septal defect, because there's a runoff at the atrial level due to the normally higher pressure in the left atrium, does not show enlargement of the left atrium. So this is on the plain films how you can differentiate the two. Patent ductus arteriosus will also show enlargement of the left atrium, and classically a patent ductus will show, in addition to the large left atrium, will also show an enlarged aorta. In practice, this is difficult to use, and the shunts have to be large before these findings prevail. Could we have the next slide, please? Can you shift that over a little bit, please? These films were made when the child was now 3 years and 8 months, and although the films look a little similar, there's definite changes. The heart actually is relatively smaller than it was on the previous films, although it's still enlarged. The pulmonary artery is definitely larger. The pulmonary vascular markings are slightly decreased in the periphery and more prominent in the hilar regions on the previous exam. And very importantly, now the barium-filled esophagus is not deviated by the enlarged left atrium. This left atrium has gotten smaller. And the reason for this is that now with the development of pulmonary hypertension, there's less blood flowing through the lungs, and therefore now the left atrium is not being distended. Now, to differentiate this from spontaneous closure of ventricular septal defect, which does happen, in that particular case, the pulmonary artery would not have enlarged. So just from the plain films, I think we have a real good correlation with the physiologic data, which the original examination, there was 2.5 times as much blood going through the lungs as was going through the systemic circulation. At the time these films were made, there was no evidence of a shunt at rest. If we have the lights, please. I have a few minutes to speak about the radiologic diagnosis of congenital heart disease. I thought I might show one of our cine-angiocardiograms. We find this extremely valuable in the diagnosis of congenital heart disease, and it's a procedure in which there's very little mortality and morbidity if the proper precautions are taken. Now, we don't have a cine-angiocardiogram on the patient that we're discussing today, and I'm going to show the film from another patient who also has a ventricular septal defect. In addition, has coarctation of the aorta and aortic stenosis. Patient being discussed today actually is the type of a patient that we've learned carries a much higher risk of injection in the pulmonary bed because of the pulmonary vascular disease. Could we have the movie, please? Now, on this film, the patient is in an oblique projection. Get that focus a little better. Catheter is in the left ventricle. The left side of the heart is posterior, the right is anterior. Here's this large shunt through the muscular septum. Now we have filling of the aorta and pulmonary artery. Here's the coarctation of the aorta here. Next injection will be in the root of the aorta. Show this coarctation to better advantage. Right through here, this tortuosity, this poststenotic dilatation. That went by pretty fast. We'll go through that Once again, here again, the left side of the heart's here, right side here, and the defect crosses through the muscular septum, right through here. Pulmonary artery and aorta. Now in recirculation, contrast media through the lungs, you again see shunting from left to right. Now in this next scene, you can actually see the movements of the aortic valve right in through here, and the mobility is impaired. Here's the coarctation. Okay, lights please.
Thank you, Dr. Deslis, for a very nice presentation. One of the important considerations in the management of patients with almost any disease, but more particularly patients with congenital heart disease, is knowledge regarding the natural history of the disease in an untreated situation. And here again we suffer from good information, but Dr. Moss, the Department of Pediatrics, is going to review this briefly for us.
I think Dr. Deslis was too modest to say that when he worked with Dr. Soames, he was very helpful in perfecting cineangiography so that it has become an extremely useful tool in the definitive diagnosis of this disease. Now, concerning the natural history of this lesion, our current concepts are based about 25% on fact and about 75% on speculation. And the facts may be listed as follows. One, as Forrest has shown, ventricular septal defects constitute the most common lesion in childhood. However, in adults beyond the age of 30 or 40, it is one of the most rare of the cardiac lesions. And this has stimulated the proposal that perhaps a good number of these close spontaneously. And it has also stimulated the proposal that perhaps a number of the functional murmurs which we hear in later childhood and in adult life may actually represent incompletely closed ventricular septal defects. Fact number two, a small proportion of these children, perhaps less than 3%, will develop pulmonary vascular changes which will lead to persistent pulmonary hypertension. And in its extreme form, when the pressure in the right ventricle exceeds that in the left ventricle, the shunt through the defect may reverse, the child may become cyanotic, and then we may have a typical Eisenmenger's complex. Fact number three, a certain proportion of these children, again probably less than 3%, will develop a protective fibromuscular band just below the pulmonary valve, due presumably to the jet from the shunt itself. And when this band becomes pronounced, it will cause an infundibular pulmonic stenosis. In its extreme form, the child may develop a picture which is identical with that of tetralogy of Fallot. And then fact number four, a certain proportion of these patients, the exact number has not yet been determined, will develop subacute bacterial endocarditis. Now, I think to understand our concept of the natural history of this disease, we must start at the beginning, and in this case, the beginning is a fetal circulation. Could I have the first slide, please? This first slide is a very schematic diagram of the fetal circulation, and the blood in the right ventricle in the fetus is ejected into the pulmonary artery, but immediately encounters a very high resistance bed, which is reflected by this narrow pathway from the pulmonary artery. Now, this high resistance in the pulmonary vascular bed in the fetus is due to three factors. One, to vasoconstriction, because the baby is hypoxemic in utero. Two, to mechanical compression of the pulmonary vessels, because the lungs are collapsed. And three, because the very small lumina of the small pulmonary vessels because the media in the fetus is very much hypertrophied. Because of this high resistance, a very small proportion of the blood flows through the lungs, probably about 15%. And the remainder elects to flow through the lower resistance, ductus arteriosus, and into the pulmonary circuit. Now, in the pulmonary circuit, we have the compartment of the placenta, which has an extremely low vascular resistance, and this is reflected by the wide pathway to the placenta. The resistance in the placenta is so low that perhaps 50 to 75% of the blood in utero continues to recirculate through the placenta. May we have the next slide, please? Now, what happens when the umbilical cord is tied? When the umbilical cord is tied, this immediately removes the low resistance vascular compartment of the placenta, and because of this, there is a slight but significant rise in the resistance of the systemic circuit. More dramatic than this, however, is the fall of the pulmonary vascular resistance. As soon as the baby is born, he expands his lungs, the hypoxemia is relieved, and this in turn relieves the vasoconstriction. The lungs are expanded, and so the mechanical compression of the pulmonary vessels is relieved, and there's an immediate drop in pulmonary vascular resistance. Now, after birth, when the cord is tied and the lungs are expanded, the situation reverses itself. The pulmonary vascular resistance is much lower than the systemic vascular resistance, and the shunt through the ductus arteriosus then also reverses itself and flows from the aorta into the pulmonary artery rather than from the pulmonary artery into the aorta. And this shunt persists for, under normal circumstances, for maybe 10 or 15 or 20 hours, and then becomes physiologically insignificant. Now, this has a profound effect upon the pressure in the pulmonary artery and upon the relative pressures in the two ventricles. May I have the next slide, please? This slide shows the course of the pulmonary arterial pressure in infants with ventricular septal defects reflected by the broken line, and also in infants with normal circulatory systems reflected by this solid line. On the vertical axis is the systolic pulmonary arterial pressure in millimeters of mercury. And let us first consider the normal infants. At birth, the systolic pressure in the pulmonary artery is about 80 millimeters of mercury. And then within the next 6 hours, there is a small but significant fall in pulmonary arterial pressure, and this is believed to be a reflection of the relief of vasoconstriction and the relief of mechanical compression coincident with lung expansion. This is followed by a more gradual fall over the next 2 weeks in the human being, which is believed to be due to involution of the media of the lumina of the small pulmonary vessels. At the end of 2 weeks, the pressure in the pulmonary artery, and therefore the pressure in the right ventricle, has dropped to the usual adult level of about 30 millimeters of mercury. Now, this is not the case when a ventricular septal defect is present. We do get the initial fall because they expand their lungs, relieve the hypoxemia and the mechanical constriction, but the involution of the media occurs at a much slower rate, and their pressure does not drop to adult levels until somewhere between 2 and 4 months as a rule. And this has profound effects upon the clinical picture which we see during the first year of life. For example, it is well known that with ventricular septal defects, we do not usually hear a murmur on the first day of life. As a matter of fact, we usually don't hear it during the first week of life, and it may be delayed for 2 or 3 or 4 weeks of life. And the reason for this is that during the early days after birth, the relative pressures in the two ventricles are so close that relatively little shunting of blood occurs, little turbulence occurs, and murmurs are not audible. When the murmur does become audible, it is first heard as maybe a grade 1 or grade 2 systolic murmur, and then gradually increases and finally reaches a stage of a harsh, loud, holosystolic grade 4 murmur, which is characteristically heard over the lower left sternal border, and which we commonly associate with a ventricular septal defect. May I have the next slide, please? Now, this slide is a diagram showing the circulation when a ventricular septal defect is present. The ventricular septal defect is located here because the pressure in the left ventricle is somewhat higher than that in the right ventricle. The blood courses through the ventricular septal defect out into the pulmonary vascular bed and returns to the left atrium, the left ventricle, and then again recirculates through the ventricular septal defect. It is easy, I think, to see that in this particular lesion, the extra load is placed upon the left heart. And this is the reason why, with significant ventricular septal defects, we see enlargement of the left atrium and of the left ventricle. Now, you will recall that when a ventricular septal defect is present, the pressure in the pulmonary artery and in the right ventricle does not drop to adult levels until about 2 to 4 months of age. When this occurs, then the shunt through the defect, if the defect is large, will reach its maximum volume, and the maximum load will at that time be placed upon the heart for the first time. And this is why when we do see cardiac failure in infants with ventricular septal defects, that we see it almost exclusively during the period of 2 to 4 months of age. It is extremely rare to encounter cardiac failure under 2 months of age, and it is quite rare to encounter it beyond 4 to 6 months of age. I think we can take that slide off now. And have the lights, please. Now, what happens to these children with ventricular septal defects? Well, recent work by Rudolph and Hoffman, who studied a large number of children with ventricular septal defects, all under 1 year of age, found that 75% of these children closed their defects spontaneously during the first year of life. Now, these children were followed by serial catheterization studies, and some of the children were catheterized as many as 5 times during the first year of life. Admittedly, some of these children had very small defects with only grade 2 murmurs, and those we would expect to close. However, there were some very large defects in the series, and some of the children even had overt signs of cardiac failure. What happens beyond 1 year of age? Well, this is for the most part speculation, although there have been some documented cases of closure. It is generally agreed that if the defect does not close during the first year of life, then the chances of closure become more remote. And the older the patient is, the less likely the defect is to close spontaneously. However, there is one case documented in the literature of a girl who was 23 years old who definitely did have spontaneous closure of a ventricular septal defect. Now, this obviously poses a very sticky problem when it comes to selecting these patients for surgery. If we elect to treat them conservatively and not to do surgery, we must recognize that although some of them will close spontaneously, some of them may develop one of the complications of ventricular septal defects, particularly persistent pulmonary vascular changes such as this child developed, and the child will certainly have a reduced lifespan and may even become inoperable. In this institution, we have jointly decided which patients should come to surgery, and we have come to lean heavily upon the judgment of Dr. Maloney and his staff in selecting individual cases for surgery, and I think later this morning he'll tell us the indications for surgery.
Thank you, Art. As part of the natural history of the lesion ventricular septal defect, we will be asking Dr. Lindy to discuss some aspects of pulmonary hypertension, Dr. Latta particularly to emphasize the pathological aspects, and then Dr. Bourne will tell us about how it occurs and appears in adults. Until Dr. Rudolph came out with his rather striking findings of, or at least for us, spontaneous closure of ventricular septal defects in children, particularly such a high incidence that Dr. Moss quoted. 75% of the ventricular septal defects that they studied in small infants appear to close during the first year of life. Until that information was available, we just assumed that anybody who had a documented ventricular septal defect would have it for life, and therefore it was our opinion that the great majority, if not all of these patients, should eventually come to surgery. Still think that the great majority are going to come to surgery. I think that this number that Dr. Rudolph is quoting is considerably on the high side. But at this time, we'd like Dr. Maloney from the Department of Surgery to present his ideas on the surgical indications and to tell us a little bit about the current risks and complications of open heart surgery for ventricular septal defect. Jim?
The decision regarding whether surgical treatment should be applied to patients with ventricular septal defect is based upon the same general principle that applies to the application of an operation for any disease, or for that matter, the same general principle applies in all of medicine, whether the treatment be medical or surgical. And that is, when the risk of morbidity and mortality of the treatment is less than the risk of the morbidity and mortality of the natural history of the disease, then one should treat the disease actively. When the reverse is true, one should withhold treatment. Now, although that general principle is rather clear and obvious, we have been faced with two difficulties in the past 10 years of open heart surgery. The first is that the risk of operation has progressively changed each year, and the second is that almost nothing was known of the natural history of congenital heart disease 10 years ago, and as more and more has become known, are applying that general principle, we've had different indications almost every year for the past 10 years. When open heart surgery began at this institution in 1955 or 56, the first patient was operated on by Dr. Longmire. We were one of the first half dozen institutions doing this type of surgery, and the mortality was high. It was about 25% for all types of open heart surgery. But an example of the progress that's been made in the past years, I looked up for this conference the figures for last year. There were 35 patients with ventricular septal defects operated on during 1964 with no deaths. The previous year there were about 45 patients operated upon with 3 deaths. So it would appear that the mortality of the surgical treatment of ventricular septal defect at the present time is about 2 or 3%. Of this mortality, probably half of 1% is related to surgical accidents, mismatched blood transfusion, and so forth. But the majority of the mortality is related to the borderline case with pulmonary hypertension, in which one takes a risk of 20, 30, or 50% when he decides upon operation. Now, in relation to operative mortality, it should be also pointed out that the operative mortality is not really determined so much by the surgeon as it is by the cardiologist and the internist. A perfect example of this is my experience at another institution, at this institution, 10 years ago. I worked in association with Dr. Tausig for some years, and it was her feeling that patients under 1 year of age should not be operated upon for tetralogy of Fallot. And the patients that we were given to operate on were in a status that made our operative procedure almost a preliminary autopsy. Our mortality was over 90%. in infants under 1 year who were operated upon with, for tetralogy of Fallot. Dr. Adams felt that many of the patients were dying who were not operated on the first year of life, and he felt that a high surgical mortality was justified because the medical mortality was even higher. And our experience at this institution, in contrast, has been that the operative mortality in the first year of life is in the order of 10 to 15%, showing the difference in case selection rather than the difference in any anything particularly related to the surgery. My second group of comments might concern our change in our understanding of the natural history of congenital heart disease. We have come to realize only in the past few years that practically all the surgery that's been done for this disease up to the present time has dealt with only 5 to 10% of all children born with congenital heart disease. The natural history of the disease has selected out most of the patients and most of the sicker ones and caused them to die early in life, and the surgeon has been in the past largely concerned with the treatment of patients who survive those early days of life. I have one slide which illustrates the type of information that's become available more recently. May I have that slide, please? This is data from Scandinavia, from Bozen and Vendel. They surveyed 1,145 cases who died in Scandinavian pediatric hospitals who died of congenital heart disease before the age of 4 years. They start out, for example, with 148 VSDs, 65 cases with VSD plus a PDA, and so forth, a total of 563 cases. At the end of 30 days, only 320 of these were alive. At the end of 150 days, at the end of 30 days, 320 had died. At the end of 150 days, 445 had died. And the residual is a very small group of patients who survived beyond those early years of life. May I have the lights, please? It had previously been our experience, may I have the lights, please? It had previously been the experience of most surgeons, and is in fact still, that operating on young infants has a high operative mortality for a great many technical reasons. I believe it's a great tribute to Dr. Adams, really, that he was, to my knowledge, the first person about 8 or 9 years ago to realize the importance of comparing the natural history of the disease with the operative mortality. When I first came to UCLA in 1955, I had learned from my previous experience certain ages for operating on children with congenital heart disease. Coarctations were operated on at 7 years, pulmonic stenosis at 5 years, and so forth. And these had been determined previously at another institution because our mortality, surgical mortality under these ages was very high. When I came here, Dr. Adams realized my prejudices, and rather than try to convince me of his point of view, which was much more aggressive from the surgical point of view than mine, instead of a frontal attack, he was very sly about it. I can remember he used to call me about 11 o'clock in the morning, 11:30, and ask me if I'd go to lunch. And I would say yes, and I'd pick him up at his office, and he'd say, "Do you mind stopping by the autopsy room? Harrison Latta's doing an autopsy on a patient. I'd sort of like to see it." And we'd go by, and it would be a tiny little infant like this with a coarctation or a simple cardiac defect that had died on the medical ward of heart failure after a couple of weeks of treatment. And Dr. Adams would look at the lesion and see that I saw the anatomy and how easy it would have been to repair it, and then he'd mumble something about, gee, isn't that a shame? We go off to lunch. And this went on for about a year, and I got the point. And he, in 1956 and 57, read papers at national pediatric meetings and cardiology meetings, in which he pointed out what now has been proven, that most children with congenital heart disease that is operable die in the early stages of life. And I can remember what a radical and what heresy he was considered to be guilty of, what radical thinking he was considered to be guilty of. And yet, in the past 2 years, I've heard or seen presented at least 20 to 30 papers in which it is now generally agreed that the real frontier for the treatment of congenital heart disease is in the treatment of the very young individual who will die if not treated in the first couple of years of life. Thank you.
Well, Jim, you give us too much credit for something that may not bear out to be true, because if Dr. Rudolph's findings are valid, as I say, it's going to be a very difficult thing for us to determine which ones really should be operated upon, and which ones are going to close spontaneously, and so on. But it is catching on. At the recent meetings in Boston, Denton Cooley had something like 1,000 cases under 2 years of age operated upon, which was just astonishing. I don't know. We have some other unanswered problems in relationship to congenital heart disease, and one of these is the pathophysiology of pulmonary hypertension. As already been mentioned several times, pulmonary hypertension, along with the congenital heart lesion, markedly increases the risk of surgery and probably the long-term survival. There are some things we do know about pulmonary hypertension, other things that we don't know. It's one of the reasons that I became so interested in the fetus, where pulmonary hypertension is a naturally occurring situation, and yet we really don't know why it goes away, so to speak. Dr. Lindy of the Department of Pediatrics is going to tell us what he knows about pulmonary hypertension.
First, I think we ought to mention what we don't know about pulmonary hypertension, and that is the cause. In talking about pulmonary hypertension, and which is another way of saying, for our purposes, increased pulmonary vascular resistance, we have to consider some of the aspects of control of the pulmonary circulation. Can I have that first small slide? This first slide illustrates one point that I want to make. Here is the normal, in the upper left, the normal adult small pulmonary artery. And this is, in a sense, the equivalent of the arteriole in the systemic circulation. In contrast to the systemic arteriole, we have a vessel with a very large lumen in proportion to a very small wall. In a sense, the systemic arteriole looks more like this picture, where the muscular media is much more hypertrophied. And in those cases of pathologic pulmonary hypertension, what happens is that this muscular medial hypertrophy progresses with and finally is joined by intimal proliferation, and finally the lumen of the vessel is narrowed considerably. Interestingly enough, the vessels in the fetus and in the newborn look more like this, and then regress to this type of picture again with the large lumen, small wall. Can I see the next slide, please? The next slide, please. I guess I can't. Can I see the next slide? So that the anatomic features of the pulmonary vessels exert one form of control on the pulmonary vessel, on pulmonary pressure. The lung volume exerts some control, so that at normal lung volumes, that's pictured in the middle here, we have the lowest pulmonary vascular resistance. And if you increase the lung volume, if you distend the lung, you get an increased resistance. If you squeeze down the lung, blow the air out, you get an increased resistance. So at normal lung volumes, we have the lowest resistance. And as you can see, this is probably related to increased pressure on the tiny capillaries between the alveoli. As the alveoli expand, these capillaries are compressed, whereas the larger vessels, the ones between the alveoli, are perhaps at their largest, at their largest when the lung is fully expanded. So these two curves, summed algebraically, give us this U-shaped curve of resistance in relation to lung volume. Can I see the next slide, please? This complex slide illustrates the change in pulmonary vascular resistance related to change in pH. Here we have, on this end side of the midline, we have acidosis, and these dots merely indicate respiratory or metabolic acidosis. And in both cases, pulmonary vascular resistance is increased over a normal resting control condition. And in alkalosis, particularly in metabolic alkalosis, indicated by the circles, resistance is decreased. The only exception to this pH rule is respiratory alkalosis for reasons we don't understand. Next slide, please. Next slide, please. Now, in addition to a pH effect with increased pulmonary pressure and increased pulmonary resistance with acidosis, there are other things which cause pulmonary vasoconstriction. Individuals living at high altitudes have higher pulmonary vascular resistance and higher pulmonary pressures and slower regression of this fetal and newborn pulmonary hypertension. And in adults and in children with congenital heart disease, hypoxia will produce pulmonary vasoconstriction. We also have ways in which this pulmonary vasoconstriction can be relieved. And this illustrates one of the ways. Here is a patient with a ventricular septal defect and pulmonary vasoconstriction in addition to pulmonary vascular change or muscular thickening. And in this case, acetylcholine injected directly into the pulmonary artery has an effect on the pulmonary artery in lowering pulmonary artery pressure, but the acetylcholine is probably inactivated by the time it passes through the pulmonary circulation, and systemic pressure is not changed. So we know that vasodilatation can be reduced by acetylcholine, and we know also that the same effect, in this case produced by endogenous acetylcholine production, is stimulated by, can be stimulated by stimulation of the carotid body. Can I see the next slide, please? In some recent studies that we performed, we injected a large bolus of material into the pulmonary artery, and whether we injected radio-opaque contrast material or dextran or saline, we got an immediate pressure rise in the pulmonary artery. In other words, this increased volume of blood in the pulmonary artery caused this increased pressure, which then subsided quickly. Can I see the next slide? This is merely a poor slide of an experiment we did in testing the effects of respiratory alkalosis on pulmonary circulation. And here on the left we have pulmonary vascular resistance. On the horizontal we have cardiac output. And you see how difficult it was to determine the effects of respiratory alkalosis on pulmonary vascular resistance, because as cardiac output increased, pulmonary vascular resistance decreased. And there's no question about it that in the normal pulmonary circulation, in these distensible, thin-walled pulmonary vessels, the main control of pulmonary vascular resistance and pulmonary pressure is the flow going through the vessels. With increased flow, these vessels distend, resistance falls markedly. And with decreased flow, the resistance, the vessels tend to collapse around the flow going through them, and the resistance of these tubes, these elastic tubes, increases. Can I see the next slide, please? Interestingly enough, this next data that we collected would make Sir William Osler turn over in his grave, but he would turn over smiling all the way. And these are some studies that we did in which we tried to evaluate how we could predict this small number of patients with ventricular septal defect who are going to develop pulmonary hypertension. And we found that the best index of an increasing pulmonary artery pressure, increasing resistance on the right side of the heart, thereby decreasing the shunt, was a decrease in the murmur. In the group indicated by the round circles, in this group in which mean pulmonary artery pressure increased, that's so-called group 1 up here, in every case the intensity of the systolic murmur decreased, as you can see on this border. So a careful physical examination was one of the best indices. In addition, the history showed definite and clear-cut findings too. Can I see the lights just for a second? The lights, please. Well, this is a very confusing field, and I heard Andre Kurnan talk Monday night, hoping to get some late pearls to present to this group. Can we have the lights, please? Perhaps not. And I said to him rather directly, Dr. Kurnan, what is your theory concerning the cause of increasing and progressing pulmonary hypertension and ventricular septal defect? And he doesn't know either. However, here's the way I feel the situation stands. We know in chronic lung disease, hypoxia, increased pH, and increased carbon dioxide tensions all cause vasoconstriction. Teleologically, on a regional basis, this is of some value, since this would redirect blood to those parts of the lung which do not have decreased pHs, elevated acidity, are not hypoxic, and are not hypercarbic. So this may be one factor. I think more likely a factor in pulmonary hypertension in congenital heart defect is related to acute distension of the pulmonary artery. We used to think that you could triple or quadruple cardiac output without changing pulmonary pressures. But we now know that even if you double cardiac output, there's a slight increase in pulmonary artery pressure, and I showed you the effect of acute distension on the pulmonary artery. And if you triple cardiac output, you get even more effects on pulmonary artery pressure. And I think that in these left-to-right shunts, such as ventricular septal defect, my own feeling is that there is a constant acute distension of the pulmonary artery, and this chronic distension, perhaps in addition with some additional pH effects or oxygen tension or CO2 tension effects, in some way causes this muscular hypertrophy of the pulmonary artery and the progressive pulmonary hypertension that we see in some of these cases. The question is, go prove it.
Well, unfortunately, not all of our patients that are operated upon survive for long terms, and some of them come to the postmortem table. And even excluding those cases, for a long time, we did routinely lung biopsies at the time of open heart surgery, particularly in those patients with pulmonary hypertension. And we've been very fortunate to have a very interested colleague in Dr. Lotta in the pathology department to help us unravel the pathology of pulmonary hypertension. Harrison, do you want to tell us your story?
The ultimate goal of physicians might be considered to be to take such good care of their patients that their services are no longer necessary. I am happy to report that in the treatment of ventricular septal defects, pathology has reached this stage of perfection. That is, my services are no longer necessary in the operating room, and this happy state of affairs has come about through a clinical pathologic study performed by Dr. Crittenden in conjunction with Dr. Adams and myself. Now let's look at two illustrative cases. The first slide, please. The first slide represents an unhappy patient a child with a ventricular septal defect who was operated on and died. Before operation, and you can see here's a sample of the pulmonary arterioles. The black line is the elastic layer of the internal elastic membrane, and inside that is this intimal proliferation that has practically occluded the vessel, as Dr. Lindy pointed out. Now, this child, before operation, was injected with acetylcholine, and the pulmonary arterial pressure did not drop. So presumably the death is due to failure of the right ventricle to pump blood through the lungs against this type of pulmonary resistance. Now, the next slide represents most of the pulmonary arterioles in a happier patient, a girl with a defect who was operated on and survived. And you see here that there is no intimal proliferation, but that we do have quite a thick media which exists between the internal and external elastic membranes and has remained hypertrophied. Her pulmonary arterial pressure dropped 30% after the injection of acetylcholine. And the next slide shows that this drop occurred in spite of a minimal degree of intimal proliferation in some of the larger vessels. In other words, this type of change did not prevent the drop and hence seemed to be reversible. Well, a larger study seemed to bear this out, and after these studies were performed, acetylcholine seemed to be a much happier way of determining pulmonary vascular resistance than a square centimeter of a frozen section, which I had to look at rather rapidly. Now let's see the natural course of events in the pulmonary vessels, and just quickly I'd like to show the next slide, which demonstrates a study that Dr. Damon did some years ago, and that while it's a complicated chart, it shows that at the newborn period the vessels have quite thick walls, thick media, and in the adult life they're rather thin, and the drop occurs very rapidly after birth in the first few weeks and months, and then reaches adult levels rather soon. The next slide shows the adult state of the vessels reached in a child 3 years of age, and the next slide shows the normal state of a newborn arteriole, which is normal, that is not hypertrophied at this age. It seems then that the medial hypertrophy either persists from fetal life in congenital cases or develops in acquired cases of pulmonary hypertension later. Now, Dr. Edwards and his collaborators have made a number of studies of pulmonary vasculature. As a matter of fact, they've just published a book of 494 pages on the pathology of the pulmonary vasculature. And the next slides are taken from them. Next slide shows that in addition that the first stages, they have 6 stages or grades of arterial changes. The first ones involve hypertrophy and intimal proliferation, as you've seen. Later, they get rather interesting changes which involve dilatation of very thin branches of the hypertrophied arteries. And these dilatation lesions supposedly occur proximal to sites of obstruction. The next slide shows angioid or angiotomatoid lesion in which a number of these thin-walled branches seem to develop from the pulmonary arterioles. The next slide shows a plexiform lesion which is caused by a plexiform proliferation of intimal tissue interspersed with vascular channels, supposedly recanalization of thrombosis. The hypertension is getting more prolonged and severe here. And finally, the last slide shows, last slide please, shows a necrotizing arteriolitis. The lights please. This necrotizing arteriolitis and some of the earlier stages are interesting for a pathologist to speculate on, because it seems to suggest that in certain respects the pulmonary vasculature is reacting to an increased pressure for it in a similar manner to the systemic vessels, which in systemic hypertension react with hypertrophy, intimal proliferation, and even fibrinoid necrosis in malignant hypertension. Thank you.
As pediatricians, we're often asked by parents what would happen if they don't have their child undergo open heart surgery and just postpone it or not do it at all. And so we immediately turn to our friends in internal medicine and ask them, well, what happens to adults with ventricular septal defect? Now, Dr. Boren's going to discuss this in a minute, but Dr. Jesse Edwards, who's been quoted several times at the Mayo Clinic, has often said that they've never had a patient come to postmortem at the Mayo Clinic with ventricular septal defect over the age of 45. And this would be people dying from all other causes included in that group. So if it's a common condition in childhood, it certainly isn't a common condition. And the problem that we're particularly confronted with is the risk any different for a girl than for a boy? In other words, does pregnancy produce any problem or complication? Dr. Boren is going to discuss this and some other aspects of the disease in adults.
Well, in all these discussions of VSD, there's this question of what happens to these people. Why aren't they seen as adults, or where are they? What's happened to them? And as has been said a couple of times this morning, it's a rare lesion in adults. And this is certainly true if you take the figure of the incidence of congenital heart disease as being about 1% in infancy and newborns, and work on and that VSD is the most common of the lesions producing this 1% incidence. Certainly there's nothing anywhere resembling this figure for an incidence in adults. However, if you consider the figures given for the incidence of congenital heart disease in school-age children, which is in a couple of series between 1/10 and 0.2%, and that VSDs represent about 1/3 of this group, and then you look at the adult incidence, it's not, the discrepancy is not so marked. In the first 100 cases of congenital heart disease seen in the adult clinic here, 25 were diagnosed as VSD and 35 as atrial septal defect. So rather than an incidence of 35 or 38% in school-age children, we see an incidence of about 25% in this small initial group that was seen here, which would indicate that perhaps we've lost about 25% of that group to account for this drop. Now, the other question that was brought up was what happens, why haven't they been seen, why don't we see them in the clinic over the age of 40? And it's true, we don't. We've had a few cases with VSD over the age of 40, but they're quite rare. And there have been two very interesting studies of the natural history of VSD published in the last year, one by Dr. Bloomfield and the other by Dr. Walker. And Dr. Bloomfield's group, he went back and tried to trace a group of the first group that had been diagnosed by cardiac catheterization and also a group that had been diagnosed even earlier by clinical means, some 12 to 25 years previously, and find out what happened to these people. And he found that among those with considered to have small defects, that they had just disappeared into the population, that they didn't see doctors, they felt perfectly well, and most of them, neither they nor physicians were aware that there were these people over the age of 40 who had a previous diagnosis of VSD. And many of these people no longer had murmurs. Presumably their defects had closed. And on the basis of some statistical manipulation, Dr. Bloomfield arrived at an estimate that perhaps 25% of the VSDs closed, and this would just about account for the difference between what was seen in childhood and what is seen in adult life. And also, in looking at the autopsy statistics, he felt that he could account for the VSDs diagnosed in childhood on the basis of estimates of their frequency, that these patients, except for this 25% that closed, that the rest of them did turn up in autopsy series. Let's see, what else? As far as our adult group goes, about a third of them have severe pulmonary hypertension, that is systolic pressures of 80 or above. And a somewhat smaller group have moderate elevations of pulmonary artery pressure, and a group somewhere between a third and a half have little evidence of disease other than the murmur. And it's certainly true that we must be missing a rather large number with similar murmurs or less intense murmurs who just don't come to a cardiac clinic, or who are considered to have functional murmurs and perhaps would have such a diagnosis even with the standard type of cardiac catheterization without more energetic attempts at finding small defects. As to the question of how these people respond to stresses and strains, there isn't much that I can say. In general, their course is, aside from the incidence of bacterial endocarditis, which will be discussed later, the patients with the small defects don't appear to suffer any consequences at all from the presence of this small defect. And the patients with the Eisenmenger type lesions with severe pulmonary hypertension remain remarkably stable for many years, but at a very reduced level of exercise tolerance. And certainly if these people, the patients with pulmonary hypertension, have to undergo a stress such as a pregnancy, they do tend to develop congestive failure, but the number of such, and have an increased mortality, but the number of such patients that have been seen are relatively small. I think there are some interesting figures about the incidence of bacterial endocarditis, which is a major consideration in these people, and perhaps we can discuss this later. There is one other thing I might mention before I stop, and that is the suggestion by Dr. Bloomfield that he found that a number of patients with small defects, insignificant defects, appeared to develop congestive failure in later life. It couldn't be related to this very small hemodynamic influence of the defect itself. They were diagnosed as congestive failure secondary to hypertensive disease or secondary to arteriosclerotic disease, and he just felt that this was a little more common in this group than one would anticipate in people with normal hearts, and raised the question that perhaps there is some deficiency in their cardiac function due to this something wrong with the septum, so that the septum wasn't contracting in a normal way, and that perhaps these people do have some tendency to have an increased incidence of congestive failure as other causes of heart disease occur with aging, and that this may be related to a defect in the septum, and perhaps this would be present whether the defect was open or closed, that the same problem might be present. But this is a matter of speculation. One of the things that should be looked for in the next 20 years with these people.
As far as bacterial endocarditis is concerned, things would pretty much take care of themselves if the incidence of bacterial endocarditis was directly related to the size of the defect. But it seems to be the other way around, that it's inversely related to the size of the defect. The smaller the defect, the greater the incidence of bacterial endocarditis. This was brought out particularly to us in a recent case that Dr. Manuelides had down at Harbor Hospital. A little child with typical findings of ventricular septal defect and no symptoms at all, normal sized heart, and I believe a normal electrocardiogram. And Dr. Manuelides said that there was really nothing to worry about except bacterial endocarditis, advised the parents about precautionary measures to prevent bacterial endocarditis, but in spite of that, the child developed bacterial endocarditis. The usual strains, came in the hospital, was treated, but in spite of the treatment, some way or other, the bacteria have decimated the tricuspid valve to the extent that the child now has marked tricuspid insufficiency, and at 4 or 5 years of age, is it, George, is going to have a plastic valve put in the heart now as a result of a very small ventricular septal defect. So this is a real problem for us, and a real consideration as to whether or not bacterial endocarditis in itself is an indication for surgical closure of the ventricular septal defect. Very glad that Bill Hewitt's here to help us discuss this matter.
As you've been told before, there really isn't an exact estimate of the true incidence of bacterial endocarditis as it complicates congenital heart disease. Figures vary between 4 and 30%, depending upon the type of patient material which has been studied and the time at which the study has been done, particularly as to whether it's before or after the advent of antibiotics. However, I think that it will be readily acknowledged that this is one of the most important complications of congenital heart disease, and certainly before antibiotics was one of the primary causes of death in connection with congenital heart disease. It's of some interest that this group of cases tends to add some confirmation to our present ideas concerning the pathogenesis of bacterial endocarditis, and I'd like to just make a few points about this. At the present time, we feel that the initial event in the development of endocarditis consists of the production of interstitial edema, deformities of the endocardium, whether it be on the valve or over myocardium, by either a swelling incident to trauma or cellular infiltrate incident to inflammation of some sort. And that on this distortion of the endocardium, fibrin and platelets are laid down with the production of non-bacterial thrombotic endocarditis. After this occurs, then the production of bacterial endocarditis depends upon a balance between the values consisting of the trauma to the valve and the deformity which has been produced and the formation of the non-bacterial form of endocarditis and the recurrence of bacteremia with alpha hemolytic streptococci, which must occur at many times during the course of normal life. So that inasmuch as one could expect that non-bacterial endocarditis on the basis of this deformity of endocardium would occur primarily in old age, incident to rheumatism, and because of the trauma related to the vascular dynamics of congenital heart disease, one might then postulate that these would be the main situations in which one would see the bacterial form of endocarditis, and that, of course, is indeed true. It's also of interest that the vascular dynamics in cases of endocarditis are relatively consistent, and that they are comprised of blood being delivered from a high-pressure source at a critical velocity through a narrowed orifice into a low-pressure sink. And it's known on the basis of physical phenomena that the main force, that is the most forceful area of fluid flow in such a situation of this, is just beyond the narrowed orifice where the fluid flow can expand. And if you pause to consider these phenomena, you will note that the vegetations in bacterial endocarditis always occur in the area of the just beyond the narrowed orifice in the low pressure sink. For example, in coarctation, the vegetations are seen just beyond the narrowed lip of the coarctation. In pulmonic stenosis, the vegetations occur just beyond the stenotic valve. In arteriovenous fistula, the vegetations always occur on the venous side of the fistula. In ductus arteriosus, one sees the vegetations just inside of the pulmonary artery where the ductus emerges into that structure. In IV septal defect, the vegetations are always on the right side of the heart, and even in this even would tend to explain the fact that vegetations in bacterial endocarditis usually are more common in incompetent types of valvular disease as opposed to stenotic valves. Now, with specific reference to IVSD, it's thought that the frequency, that is a reasonably good estimate of the frequency of bacterial endocarditis, would probably be around 10 to 20%. And one of the questions, of course, well, there are really two questions that come up as to whether this complication is an important consideration in terms of surgical repair. One is, does surgical repair decrease the incidence of bacterial endocarditis? And this is a question, I think, which is really a little bit difficult to answer, since there have been instances of bacterial endocarditis reported following repair. And it's, I think one of the questions I would like to have answered is also, what is the frequency of really perfect repair of this defect? Another important question which comes up is, what is the risk really from the standpoint of infection with this complication? And knowing as we do that alpha hemolytic streptococci are the primary cause of this complication, this is a really readily preventable and also readily curable disease at the present time, and especially is this so in patients in whom there is a high index of suspicion. To some extent, this seems to me to be a problem of education, and is somewhat analogous to the cases of meningitis which occur in patients who have been subjected to hypophysectomy. In spite of the fact that this complication, that is meningitis due to gram-positive organisms, is a highly fatal disease under ordinary circumstances, in spite of the fact that we've had certainly a number of instances of this complication in patients of this sort long after they've been discharged from the hospital. We have yet to see a patient who has not been controlled with ease and who has not recovered even after more than one episode of this complication. Also, it would seem to me that the risk of bacterial endocarditis in patients with septal defect, particularly where at least ordinarily there is no valvular involvement, is relatively minimal. And in the patients with IBSD and bacterial endocarditis that I've seen, the control of the disease has been easy, and there has been no subsequent indication that alteration of cardiovascular dynamics has occurred. I'm very interested to hear about Dr. Adams' case, and I wonder if others have had similar experiences in terms of valvular involvement.
Well, in answer to that last question, I think Dr. Longmire had we had a little girl that the tricuspid valve had been virtually eaten away with bacterial endocarditis, as I recall. So that's two I know of, but I don't know if any in the audience have had any. We have several minutes left over for questions, and I think the speakers themselves ask questions of the other speakers. Anybody like to ask a question at this point? Did you want to make a comment, Bill?
Well, Dr. Adams, I'd just like to ask a question to bring out a belief. And that is, I'd like to inquire what the evidence is that Dr. Rudolph presents to support the closure, spontaneous closure of these defects.
Certainly, and
in seeing these defects at the operating table and their characteristics and so forth, I would be extremely skeptical that the type, at least that we operated on, would ever close spontaneously.
I think that's right. Dr. Moss, do you want to answer Dr. Longmire's question?
You're right, because his data were based purely on catheterization studies using oxygen saturation techniques. So small defects could have escaped detection.
Dr. Lindy?
In talking with Dr. Rudolph, I think his findings are extremely interesting. I don't think they're going to change ventricular septal defect as we know it, because he selected patients for this study on the basis of minimal type of murmurs, such as we hear in perhaps 50% of newborns. And these are murmurs which formerly we tended to ignore. The bulk of his patients were patients without cardiomegaly, without ECG evidence of disease, and these are the kind of murmurs which we knew disappeared. And it's been known that 50% of newborns have murmurs. I think this is the pool that forms the bulk of his cases, and the kind that we see, I agree with Dr. Longmire, are going to continue just as we see them. And I think the incidence of closure in the child with the roaring murmur who has a large heart and ECG evidence of disease, the incidence of closure is still very small. And the high incidence that Rudolph gets, I think, is entirely related to his patient selection, which he admits is not the usual, is not based on the need to help them clinically, but was based on this research interest.
There are some that have closed, and then the surgeon has gone in and looked to see what's happened, and several in the literature where they've actually had pulmonary hypertension with large left to right shunts and then have closed. And usually these are muscular defects. There's still some evidence you can put a probe through, but the overlapping of the musculature has occurred in such a way that it's virtually closed off the defect. Ray?
This may be true of Rudolph's series, as you said, but these other two series, that of Walker and the cases described by Bloomfield, where Walker, I think, found about 10% of the small defects had closed on recatheterization, and this other estimate on a somewhat more nebulous basis of Bloomfield's of 25% closing. These were patients who were brought to the doctor because they had something that needed diagnosis. This was not looking up patients with these relatively insignificant murmurs to catheterize.
Dr. Manuelides?
Yes, just to add a few more words about the Dr. Rudolph's series. When he selected his patient from his own nursery, he found this figure of 75%. When patients were referred to him because of cardiomegaly, murmurs, symptomatic VSTs, then he found that the incidence dropped down to 20% to 25%. And so this comes well with figures of Bloomfield and the other water. So when you catheterize any child who has a murmur, you will find a very high incidence of the small VSTs, and these close, most of them. They don't even come to the attention to the average cardiologist, I will say, in these cases. They come and go in the first year of life without, we hear the murmurs, we follow them, everything is normal, and then they close.
Somebody had a question back there. Yes.
I'd like to ask a question whether following pulmonary banding or repair of the VSD, do the pathological changes in the lung reverse themselves?
Dr. Mulder, I'm looking straight at you.
I'm not
You want
sure
to comment
why,
on that?
I would think that the answer to that question would be very difficult to be certain. I say that because there is some evidence to suggest both. Namely that people who have had a banding procedure, young infants in trouble early in life, who then have been re-explored, say 4 or 5, or in one instance I know of as long as 6.5 years after the banding, their lung biopsy and their subsequent course suggested that there had been no change whatsoever in the peripheral resistance or pulmonary vascular changes. In other instances, children who have been banded, who then have been re-operated at some future date, there have been changes progressive in the proper direction, and the clinical course has gone along with that. So I think this is a highly variable thing, and I'm afraid there's no real simple answer to it.
Any other questions? Dr. Latta?
I'd like to continue on that one if I could. The supposition, of course, is usually that hypertrophy is reversible and fibrous proliferation is not. But it would seem to me that you could answer this question also from acetylcholine injections in a patient, or giving you a determination of changes in the peripheral resistance or pulmonary flow at the time of operation, or around the time of operation, and sometime later. Can you?
Well, I think the point is valid. I don't think it's been done. One of the problems in studying patients who have had a pulmonary artery banding is to get the catheter into the pulmonary artery distal to the band, and this is very difficult to do. But it should be done, I think. Any other questions? Well, I'd like to, Harrison?
I'd like to ask Dr. Lindy a question. Usually in the physiologic mechanisms play some role in the wisdom of the body. What is the wisdom of pulmonary constriction in hypoxia? Why do people at high altitudes have a constriction of their pulmonary arterioles?
Well, this was a very difficult system. As far as the control systems, this was a very difficult one to do. And the way he figured it out was this. He said, if you're going to place he with a capital, if you're going to,
I thought you were talking about that.
If you're going to place an individual in a spot where there is a low oxygen tension, he's out of luck. But if you're going to place one lung lobe in this situation, and let's make this one lung lobe atelectatic, so that air exchange cannot occur. And this, any circulation that comes to this collapsed lung lobe, in which air is not being ventilated, is then exposed. Any CO2 which is carried by the blood will increase the acidity of this lobe, decrease the pH, increase the carbon dioxide tension, decrease the oxygen, and the blood will not be oxygenated, and all of these factors will cause vasoconstriction. Okay? The blood flow from the right heart to the lung will then be exposed to one lung lobe which has increased resistance and the rest of the lung lobes which have normal resistance, and this is teleologically, the blood will be redistributed so that circulation will go to areas which are well ventilated and which will avoid areas which are poorly ventilated. So he was able to do this on a regional basis. He figured it, as far as the total picture, if you're getting that situation, you're on your own.
Well, I think it's 9:30 and you're all on your own.